As all of us knows, that infection prevention and control plays a very important role in day-to-day practice. Previously, when we did MD, MBBS from our medical colleges, IPC and quality used to be an thing extra we are doing to our work. But now it is not like that. It is a part of your work, and as a part of your work journey, you have to implement in daily practices. So here we have gathered today here to gain the knowledge from all the esteemed speakers and the chairpersons. What is the importance of infection prevention and control and the global scenario of AMR and what's going on that. We have seen in the near past many bugs have come up, especially the India is really suffering with gram-negative sepsis. And even if you see the Western pattern, previously gram-positive infections used to be very high in the Western areas, but now there also gram-negative sepsis has become a real threat to them. In our hospitals, we see on daily basis where the E. coli and Klebsiella and many other microorganisms coming, multi-drug resistance and XDROs also, and sometimes we have come across PDRO. Recently, I've attended one ID consult, CME 3 days back, where they were discussing about the pseudomonas, which is PDR. Even I believe I don't know how they have tested. They are resistant to ceftazidime, maybe bacterium also, the new antibiotic in the pipeline. So that is why the scenario is there. Previously, we used to have very few antibiotics and very few organisms were there in the mind. Like if anyone get an infection, we thought of like either he may have the enteric fever or a malaria or maximum tuberculosis. But now the scenario is totally changed. Unless you know the bug, you cannot treat it. And just knowing the bug is not enough. You also need to know what type of resistance they have inside. Then only you can plan your AMR, antimicrobial MSP, antimicrobial stewardship program properly. Otherwise, you will end up in having the resistance to the all the antibiotics which we have. And one more important point I would like to share in this platform is that few antibiotics are very dangerous to use. So as a clinicians, when you are prescribing, just keep in your mind, we have seen after COVID, I would say the irrational use of antibiotics, especially macrolide groups and also the clavulanic acid, which is being written left and right for all the LRTIs, community acquired, which is a potent inducer of the MDROs, MCs and ESBLs. So we have to be very vigilant and the clinician has to join this type of seminars, and the microbiologist role is more clinical now to guide the clinicians and also the infection control practitioners in properly planning the antibiotic. With this short thing, I would like to invite Sir Rahul Kamble sir to take over the session. Thank you.
Thank you, sir. Thank you, sir.
A very good morning to all. It's indeed a great pleasure speaking at this esteemed platform in front of such an esteemed dignitaries. I am very thankful to the organizing committee and especially Dr. Kamlakar sir for giving me this opportunity. It's a short time. I will quickly begin with my presentation. AMR is a huge topic. It will take months if you speak on this vast topic. I will try to cover as much as possible in the short span of this session. Before I start, I will share my learnings to this presentation. I was involved as a project lead for developing hospitals across 7 states of India, a center of excellence for antimicrobial stewardship. It was a project wherein I worked with CAHO also. I was the project lead. I certified 11 hospitals as center of excellence for antimicrobial stewardship across 7 states. So we'll be sharing those learnings through this presentation. It was not a simple task. There were multiple challenges. There were multiple states and different categories of hospitals. Will try my best to ensure that the participants achieve the expectations. Let's understand why we call antimicrobial resistance as a silent killer pandemic. We call antimicrobial resistance as a silent thing because unlike other infectious diseases like dengue, chikungunya, malaria, and other such things, we don't detect antimicrobial resistance. We lose so many people. So there is such a high rate of mortality, but we don't identify or analyze how many of these mortality cases are due to because of MRSA or CRE or ESBL or colistin resistance or MDR pseudomonas and other such things. There is no data at a national level or state level of true data which says about the loss of the deaths because of such antimicrobial resistant organisms. So that's one of the challenges. That's why we call this antimicrobial resistance a silent killer pandemic because of the high rate of mortality and morbidity. However, it's not just a problem related to only to hospitals, healthcare settings. It is an ecosystem challenge. It is not just a microbiological phenomena. It is a system challenge that demands global vision, a national commitment, and a local action. I begin with my presentation with a message and will end up with a similar message. Every prescription is a public health decision, and every infection prevented is an antimicrobial preserved. So, why we are talking about AMR? Antimicrobial resistance is a global crisis which demands local action. AMR is one of the greatest threats to modern medicine. Now we have seen modern medicine, we have seen robotics and other such advances in medicine, but the modern medicine will be failed if the antimicrobial resistance becomes a serious issue. Antimicrobial resistance is a serious threat to patient safety. It's a threat to the healthcare system because of the loss of resources. It's a threat to it's a threat to the global health, and it affects the life-saving procedures such as organ transplantation and chemotherapy and others. So that's why AMR is one of the greatest threat to modern medicine, and there is a role in the healthcare setting at all levels, starting from government, hospital, clinicians, microbiology labs, pharmacists, nurses, and patients. WHO recognizes AMR as a major threat affecting human health, animal health, agriculture, food system, environment, and a sustainable development requiring a One Health approach is required. India's National Action Plan AMR 2 also identifies AMR as a serious public health and development challenge driven by misuse and overuse of antimicrobials in humans, animals, and plants with disproportionate impact on low and middle income settings. The national strategy therefore adopts a One Health approach. That's the change that we have seen in the National AMR Plan Point 2 as well as the revised WHO Global Action Plan. We have seen a multi-sectoral approach requirement to deal against AMR. Now, what's the burden of this AMR? It's a silent pandemic with devastating health and economic consequences. AMR is already causing millions of deaths. About 1.14 million deaths were directly attributable to bacterial AMR in 2021. 4.7 million deaths were associated with bacterial AMR worldwide. So, without effective interventions, up to 39 million cumulative deaths could occur by 2050. Low and medium income countries bear the greatest burden of AMR. The clinical consequences includes treatment failure. Now, as sir said, there we have seen a resistance to ceftazidime avibactam, but there are some cases also where we have seen resistance to ceftazidime avibactam plus aztreonam also. So we are trying multiple combinations. We are trying antibiotics at higher doses, and we are seeing resistance to those antibiotics also. So empirical therapy is also not working because the plethora of organisms post COVID has changed. Previously, we used to see E. coli, Klebsiella, and other organisms, but now the organisms are different. It's like Pseudomonas, Burkholderia, Acinetobacter, Stenotrophomonas, Candida auris, and others, which respond very poorly to the empirical therapy that we use, mostly the third generation Cephalosporins. ESBL resistance that is about 80 to 90% prevalence. So it's time that we realize it's a high time that we realize to use the antibiotics rationally. The main issue in the Indian setting is that we don't have a central surveillance mechanism. We don't have the data about the multi-drug resistant organisms. Neither the mechanism that we use to detect the antimicrobial resistant pathogens, that is a breakpoint. CLS and UCAS is from US and UK practice. We need our breakpoints in Indian settings. So then the data will be further more serious if we use the Indian settings breakpoints. That's one of the challenge and a requirement in India. So the WHO Global Action Plan, I repeat again, it is mentioned that it is AMR threatens human health, food system, economics, and sustainable development, making it a multi-sectoral challenge. Even the India's National AMR Plan mentions about the same. Why is India a priority country for AMR? India carries a high burden of infectious diseases. India is one of the leading country of consumption of antimicrobials. Also, we see that the antimicrobials are not properly discarded or disposed. Not from the healthcare settings, but also from the community settings. We don't see proper disposal of antimicrobials. These antimicrobials enter the environment and further leads to antimicrobial resistance in the environment. So that's another challenge. That's why India is a priority country for AMR. If India's success in controlling AMR, it will be significantly influence the world's success in controlling AMR. How India is responding against AMR. The national priorities include strengthening the surveillance, strengthening antimicrobial stewardship, infection control, having a One Health collaboration across all sectors, strengthening the research and innovation, and having governance and accountability at all levels. The four pillars of One Health includes human health, animal health, agriculture, and food systems and the environment. One Health, as mentioned, what WHO and National AMR plan, what is One Health is an integrated multi-sectoral approach, recognizing that the health of humans, animals, plants, and the environment is interconnected. The different sectors that play key role in with using this One Health approach against AMR is Minister of Health and Family Welfare, Minister of Fisheries, Minister of Agriculture, Environment, Research Institutes, state governments, and healthcare organizations. The message is from the slide is think globally, collaborate across sectors, and act locally. Everyone has a role in this battle against AMR. If you see the clinicians, they need to prescribe rationally. The microbiologist needs to guide the clinicians on how to interpret the MIC values. Now if we see the AST reports, most of the settings I see, we see that it's just a sensitive or resistance that we are reporting. But the microbiology reports will make a mention of the breakpoints, the therapeutic index also, which will guide the clinician in selecting the right antibiotic. Also, the clinical pharmacists should help guide the clinicians for the pharmacodynamics and pharmacokinetics of the antimicrobials. Infection control nurses and the link nurses should see that about the prevention and control of hospital-acquired infection, while hospital administration should come up with a commitment with a proper allocation of resources for the programs. Now, why did the WHO change this plan? WHO has had launched this plan of global AMR action plan in the year 2015, while India had launched this AMR action plan in 2017. There was a change because the first AMR action plan, the previous AMR action plan, focused on sensitization of the healthcare settings. It's focused on creating awareness and understanding. But now we have moved from awareness to action and from policy to implementation. From 2015, we have moved from awareness to development of national AMR plan, then state AMR plan, stating the surveillance, sensitization for the stewardship program. While from this plan of 2026 to 36, there is a more focus on implementation of this plan, having an accountability, institutional accountability, hospital responsibility, strengthening the innovation, and a One Health approach for a measurable impact. The world has made progress since 2015. There were multiple significant challenges like healthcare challenges, system challenges, and One Health challenges. Yet, more than 170 countries have developed a national AMR action plan. AMR has become a global political priority. There is an expansion of the surveillance system, that is GLASS system, global antimicrobial surveillance system. There is increased focus on infection control. There is a growth of the AMS programs and greater recognition of the One Health approach. India's National Action Plan on AMR focuses on state and surveillance, infection control, antimicrobial stewardship, One Health collaboration, research and innovation, and governance. Now, what's the goal of WHO? WHO goal is to preserve antimicrobials for future generation through a One Health approach. Its vision includes protect the human health, animal health, ensure food security, promote sustainable development, strengthen global health security. Its goal is to prevent infection, preserve the antimicrobial effectiveness, improve the patient outcomes, strengthen the surveillance, encourage innovation. The strategy is prevention of infection at the first step. If you prevent the infection, logically there won't be an issue of antimicrobial resistance. Early detection, as Sir also said, early detection of the antimicrobial resistant organisms is important. We can have a policy or a protocol in the healthcare settings to early identify or screen the patients who comes from a high risk, who are high risk cases, like people who have been patients who have been on isolation or coming from outside settings or with devices, to screen them for MRSA or CRE. So it will be the first step to prevent such patients developing multi-drug resistant organisms later. So early detection is the key. Following evidence-based guidelines, having stewardship protocols in place, and then surveillance mechanisms, setting the research and innovation, and sustainable governance are other strategies. What's the theory of change of WHO? The WHO theory of change includes implementation of the global action plan, the national AMR action plan, and also the state action plan. Hospital leadership to take the commitment, have a AMC programs, that is antimicrobial stewardship program, infection control programs, and diagnostic stewardship. Now, these three things that infection, we stepped much early into antimicrobial stewardship, but the first step will be diagnostic stewardship. If you have the right right diagnostic for the right patient at the right time, we can detect we can detect and prevent the infection early. Diagnostic stewardship, antimicrobial stewardship, and infection control can be the three of these things. The triad can be called as a theragnostic medicine or a theragnostic approach or model in this fight against AIDS. The global action plan includes leadership and governance, having a behavioral change that is one of the strategic objective, stating the surveillance, infection control, responsible antimicrobial use, and One Health collaboration. So I'll go to the five strategic objectives of WHO and our role for the same. The WHO strategic objective 1 mentions about improving the awareness and understanding of AMR. It is said that eyes cannot see what the mind doesn't know. Uh, uh, gen, uh, the healthcare professionals should be aware about the antimicrobial resistance, the pathogens, how to detect it, and to prevent and control it. If there is a behavioral change, if there is a knowledge improvement, there is an understanding of the antimicrobial resistance among the healthcare professionals, there will be an attitude change, there will be a behavioral change, and then leading to appropriate antimicrobial use and reduced antimicrobial resistance. How India is addressing this national action plan strategic objective? Is achieving this through stating the education. AMR is incorporated into the medical, nursing, pharmacy, and veterinary education. Continuous CME programs, skill development for healthcare professionals, capacity building for lab professionals. Then India is having public awareness campaigns like World AMR Awareness Week in the month of November, Infection Control Week in the month of October, community awareness initiatives, school and college education programs, development of IC materials, digital and social media campaigns. Then we are having capacity building in healthcare facilities like we have today, training in antimicrobial stewardship program, infection control education, diagnostic stewardship training, standard treatment guidelines dissemination. Then stating the lab capacity, lab competency, lack of diagnostics is one of the challenges that hinders us in identifying of the antimicrobial resistant organisms. That's one of the challenges. So training the healthcare, the diagnostic professionals in culture and such as testing, quality assurance programs for the same, standardized reporting, interpretation of the antibiograms. Now, antibiograms needs to be a real time. It should be shared department wise, organism wise, syndrome wise, and every healthcare professional who is prescribing the antimicrobial should be aware of this antibiogram. And the basis of this antibiogram, there should be a local antibiotic policy. Then One Health awareness also is one of the strategy. Education across human health, animal health, agriculture, and environment is required for a coordinated action against AMR. So, what is our role in the strategic objective? There are role across different stakeholders: clinicians to prescribe optimally the antimicrobials, microbiologists to guide the clinicians for selection of the right antibiotic, have the right diagnostic for the right patient at the right time. The microbiologists can give the microscopy values, the gram stain or the AB stain values immediately, so to guide the clinicians for the selection of the right antibiotic, give the provisional diagnostic report at the earliest. The clinical pharmacists could guide the clinicians with the pharmacodynamics and the pharmacokinetics. Nurses will be involved in the prevention and control of infection and implementation of the infection control measures. Hospital management should come up with a commitment and accountability and optimal allocation of resources for these programs. Regarding patient and families, the patients and the families are expected to complete the treatment, the full course of treatment, not to be defaulters, not to take the over-the-counter antimicrobials. Now, these are the strategy that has been mentioned in the strategic objective of WHO, hospital implementation strategy, daily action, review for the daily action, monthly action, and the annual action. The daily actions include review every antimicrobial prescription, encourage the cultures before antibiotics. After antibiotics, if the cultures are taken, it will give a negative only. So, encourage the cultures before antibiotics when clinically appropriate, follow the local antibiogram and antibiotic policy, practice hand hygiene, the single effective measures to prevent infections, document the indication of the antimicrobial prescription and the duration also. Multiple times we have seen that surgical prophylaxis is given before the surgery and for days it goes on continuing. There is no stop for the same. Also for post infection also, there is no such stoppage of the antimicrobials documented. So that there should be documented of the stoppage of the antimicrobials, educate the patients during every encounter. Then monthly actions include having a AMS meetings, IPC meetings, having a prescription audits, feedback to the departments, that's more important, having awareness sessions for antimicrobial resistance, and a dashboard review regularly. The annual actions include having a hospital antimicrobial publication, staff competency assessment, AMR awareness campaigns, and policy review and updates. I repeat again, every prescription, every culture collected, every hand hygiene opportunity, and every patient education conversation contributes to the fight against AMR. WHO has sets the agenda, but India develops the strategy, hospital implements the system, but success ultimately depends on the daily action of every healthcare professional. It's a responsibility of every department, it's a hospital-wide culture. That was about the strategic objective one, that is education and awareness. The strategic objective two mentions about stating the surveillance and research. It is said that you cannot manage what you do not measure. Without surveillance, stewardship becomes guesswork. Data transfers antibiotic prescribing from opinion to evidence-based practice. So why surveillance is critical? What pathogen, it helps us to understand what pathogens are circulating, which antibiotics are effective, what are the resistance rates that is increasing. As I started in the beginning, we need a central surveillance mechanism. We will start with hospital levels and state levels, which will help to understand the antibiogram, how hospital interventions are working, what should be our empirical therapy, as the plethora of organisms has changed, what should be evidence-based clinical decisions. The suggested KPIs include blood culture contamination rates or the percentage of cultures obtained before antibiotic initiation, the MDR organism trains, the antimicrobial consumption, and the hospital acquired infection rates. So India's response to the strategic objective 2, that is stating the surveillance, includes ICMR objectives includes the monitoring the resistance trends, standardizing the lab practices, generate the national AMR data, support evidence-based treatment guidelines, strengthen the research collaborations. While NCDC is involved in the surveillance, getting the public health response, outbreak investigation, capacity building, and World Health coordination. The WHO GLASS, that is Global Antimicrobial Resistance and Surveillance System, purpose is to standardize this global surveillance, international comparison of AMR trends, data sharing among the countries, and support the global policy decisions. What is our role? Have a culture collection at the right time, have correct lab testing, give a correct AST report, have a AMS committee, develop a hospital policy, have a clinical practice as per evidence-based, see that the patient outcomes are effective, and have a continuous surveillance. The core components of AMR surveillance includes microbiological surveillance, antibiogram development, antimicrobial consumption surveillance, healthcare-associated infection surveillance, and early warning and outbreak detection. There are real-time antibiograms that gets generated from automated systems like Bacti-Alert and Phoenix, which can help the guide the clinicians for the right anti.
One book is All-in-One Quality Assurance Execution with AI-linked Technology, a comprehensive handbook. The other one is All-in-One AI-linked Technology Implementation Comprehensive Handbook. Sir, I request you to say a few words. You will come there?
I will stop. I don't need to hold my hand to hand. Can you hear? No. Hello? Can you hear?
Yes, sir.
Okay. First of all, good morning to all of you.
Good morning,
Be
sir.
active because
Good
don't
morning,
be
sir.
dull. Enjoy the process. Before I could talk a word, I want to my gratitude, sincere gratitude to Ramdev Hospital. I consider them, whoever does the service to the patient care, healthcare services, I salute them. That is for them, the nation is first, the rest is next. We don't see their sacrifice. We don't see once the hospital means we have some impression. No, that's not the truth. The truth, they spend years of thinking, doing, sacrifice the family, do something they have want to do and they have done it. Please, the great, we have to be great. And distribution of Satyanarayana names I don't know, but all are honorable people. What they inspire for others. He has come with that age. I am 88 years. I am also 88. But he has come to only to inspire you young people. Please learn. This conference is not just come and talk and go. You have to take it. Paisa vasool, every 1 minute, every rupee has a value. Make it, this is an opportunity. People have come from for this Delhi, Bombay to help you, give you something, contribute you something. That is healthcare. We take quality, we read books. We see the Google, everything you get. If you want to know Dr. Professor Mugli, you ask one question in the Google. Who is Professor Mugli? You will get the answer. But don't need to come here. But we have come here to see, get inspiration. Anyhow, I don't want to talk. Thank you so much, sir. First of all, I pray for the distinguished, our honorable guests sitting here. I am sure outside they are also sitting here. I don't say. There are many senior people. I have respect for all of them, not only over dais, off dais. Coming to this book, I will tell you
Okay, sir.
what I want to tell you. Sorry, you hold it.
Okay, sir.
Oh, better. I want this number one book, these two books, what I have written generally for next 10 to 20 years. Not now. You will see the next 10 years. Hospitals, you don't see us. Robotics, they will be receiving you as a front desk. They will ask you, Gentleman Yusuf, how are you? Come on. You will say, you show the card, you will say, oh, you have this problem, you will take you to the concerned OPD. That will happen. Then I will talk in my lecture something more. But I will tell you what is the advantage of this book and this book. This book has all in one comprehensive covers from the top to bottom, top to ground level, that is federal, central government, state government, regional, hospital, public health, and grassroots level, primary health. All this can use. Number two, why they use? To make standards, policies, procedures, and rules, regulations, how to implement in the healthcare organization or the hospitals. Understand? Then, second, to effectively implement this, that's why 108 chapter covers everybody, including medical, nursing, allied healthcare, paramedics, including then support services, even managerial, all those. And then also, on this, in addition to this, companies, drug companies, manufacturing of instruments, surgical instruments, they also have to have this information. It covers all of, that's why 108 chapters, 730 pages. Second thing, to have a effective implementation, you should have a check and balance. That is quality. This book will make you them. This book has advantages. What are the advantages of artificial technology? Those technology has advantage, but every rose has a thorns. Those thorns, that is setbacks, problems. It takes preventive measures like a macrobiology. Today they talk how to prevent the diseases. This is how to prevent the robotics could not play too much role. We have to control, otherwise a servant will sit on your head. Coming to what is the advantage of this? Who uses, I told you, starting from top, hospital level, doctors, nurses, allied health, everyone, including bill section, insurance, ethical, legal, will be using this book. Everything, 108 chapters. And this has a control. There's a security man standing by our side. Don't do this, do this. Coming to next. That's why I move here and this. So keep it. You follow me. Next, how it is useful. It is not a book about how it robotic, artificial intelligence, or functionality of them, or machine learning. It's not a functionality, but it is an antidote, controls them. It tells you, it's not a book how you prepare robot. We are not computer people, we are not a manufacturer company. But we know how to get work done. The advantages. Second thing, it has a tremendous advantages. People who use it, it has to be not only that, it is a advantages, helps you, the users, maximum advantages. Wherever there's setback, the books comes to control, prevent them. That is this books. It is both have control and using. Remember this. So I don't want to take much of your time because it's already there. So I will be talking about this. These two books are essential for everyone. talking from central government, federal government, they know what to do at the national level, what to do at the state level, what to do at the hospital level. Hospital is the executive. They are the only rules makers, policy makers. But working, you and me at work, that is the hospital staff. And that this book is useful. These two books are available here, in fact, in the bookstore. That's not the point. I don't think I have come to sell books. You should know these books are there. What I have done, what I presented in Melbourne in 2000 about the what you have, the wearables, 2000 in Melbourne. Now you're saying people from the house, the patient need not go to hospital. Doctor can, I will tell you that. He will sit in the room for general cases. Then he tells the doctor, sir, I have this problem. The reports are he gets. Doctor from there he prescribes. Nowadays everything online payment. Next half an hour, a Swiggy brings to not dinner food. He brings the medicines. Knock at the door, get the medicine within half an hour. That is given in 2000, Melbourne. And it's happening now. It's happening. I have that paper, but I don't want to show that. This I have no. Next 10 for 30 years, 20 years, I may not be alive. I will tell you everywhere, but don't think robot will rule us. No, don't have the fear. We are the masters. I will tell you that. Robot is a servant, is a friend, is an associate, but master you. As long as this universe exists, no robot, whatever capability, will never overtake. The human being is the master, that you remember. With this, I want to tell you, ladies and gentlemen, thank you so much for giving this opportunity for all of you. It is not on behalf of him, this opportunity to learn something extra and go back, not just books and all you can read at home. Thank you so much for everyone. Thank you, sir, for giving the opportunity to be here.
Thank you, sir. And also, Dr. Mowgli sir is so generous that he told me that a set of 6 books written by him, they are being given as a complimentary to all the faculty who are part of this organization. There are about 60 members who are chairpersons and who are speakers. All of them will getting a set of 6 books as a complimentary. If we miss to give it, Mustafa sir, please remind us, we'll give it. Now we move to the most important session, the keynote address from Dr. Giridhar Gyani. Do we have the AV of Dr. Giridhar Gyani, sir? Dr. Giridhar Gyani, sir, Professor Satyanarayana, sir, Dr. Mowgli, sir, Dr. Yobu, all the distinguished guests for this inaugural session of our inaugural conference organized by Ramdev Rao Hospital. A very good morning to you all. I am the opening batsman today, but when I was playing cricket, I was not fond of opening. I used to be in the middle order. So there is some amount of nervousness as an opening batsman. Unless the opening batsman scores heavily, the rest of the sessions will not go well. That is why, although I am fond of talking extempore, today I have come with a paper which is already typewritten, because all my team members know that I don't resort to getting a speech prepared. On the occasion only I will be speaking. But I didn't want to happen it like that, and I thought it will be better if I prepare and deliver the address. More so it is because it's opening address of the opening conference. It is indeed a memorable day for all of us at Ramdev Rao Hospital, a not-for-profit organization that started about 2 decades ago as a 10,000 square feet facility providing only basic services. Initially, it was zero billing, but when numbers increased, service is being provided at an affordable cost. As time passed, more services had to be added through an organic growth. It has now become a 95,000 square feet facility. The vision of the management is quality care at affordable cost. The management undertakes any expansion plans that will result in the good of humanity. Sir, this phrase good of humanity I have borrowed from you only. The last 6 years have been significant expansion of the organization. In addition to adding super specialty diagnostic and therapeutic services, realizing the resource crunch, the management has taken a decision to start a nursing college, and the first batch of GNM students are now ready to join us, and a BSc students will follow shortly. The education is also being imparted at an affordable cost only. The quest for quality accreditation started in the year 2018 when Ramdev Rao Hospital decided by the then medical director Colonel Dayakar that they should go for NABH entry level accreditation. Then the hospital followed HCO accreditation in 2023, Nursing Excellence in 2024, Digital Standards in 2024, ER certification and NABL entry level in the year 2025. At the same time, it was felt that we need to commence some academic courses as well, and our hospital got accredited for conducting IDCCM courses which are being run by ISCCM and MEM courses in ER with semi-recognition. That is when the management decided to have an auditorium also in the same campus. It is rightly titled Chaitanya Memorial Center, where they expect the conversations taking place should spark developments that will benefit humanity. This is the message which Vikram Dev Rao Garu gave on the inauguration of this auditorium on the 25th of April. Sir, these words coined by you continue to ring in our ears, and as a beginning to that endeavor, we have planned this 2-day national conference. For this inaugural conference at the CMC, we have with us stalwarts Dr. Giridhar Gyani, who started NABH quality standards in hospitals in our country. Dr. Satyanarayana, who started the Department of Hospital Administration at NIMS. Dr. J.D. Mowgli, well known as the father of medical records, whose books are being released today. A distinguished set of guests we have. Sir, we are fortunate to have several renowned speakers in the coming days for this conference, and we thank all of them to have accepted our invitation at a short notice, and we are looking forward to enlightening presentations from them. We already had one from Dr. Rahul, chaired by Dr. Mustafa. With these words, I invite Vikram Dev Rao Garu for addressing the delegates and guests. Thank you.
Dr. Giridhar Gyani, Dr. P. Satyanarayana, Dr. G.D. Mowgli, Dr. Kamlakar, Dr. Yobu, distinguished dignitaries, delegates, ladies and gentlemen, a very good morning to you all. I have the privilege of serving as the president of Ramdev Rao Hospital's Sivananda Rehabilitation Home and the Chaitanya Memorial Education Society. The Chaitanya Memorial Education Society is the promoter of the Chaitanya Memorial Center, the auditorium in which we are gathered today. These three institutions have come together over the years to create the infrastructure and ecosystem that you are experiencing today. Their journey is one of service, compassion, and a steadfast commitment to improving lives. Our story began with the Sivananda Rehabilitation Home, founded by my mother, Srimati Kumudini Devi, who purchased this property in 1958 with the vision of establishing a center for the treatment, cure, and rehabilitation of destitute persons affected by leprosy. What started as a noble mission grew into a beacon of hope. At its peak, Sivananda cared for 950 persons with leprosy, providing them with shelter, food, clothing, medical treatment, and vocational training. Once cured, they were equipped with skills that enabled them to reintegrate into a society that had often marginalized and rejected them. Today, Shivananda continues to serve as a major center for the treatment and care of persons affected by leprosy, carrying forward the values of dignity, compassion, and inclusion upon which it was founded. As the years passed, we observed another growing challenge. Quality health care was becoming increasingly inaccessible to middle and lower income families due to the rapid corporatization of healthcare and limited expansion of public health services. Recognizing this need, the board of Shivananda took the decision to establish a hospital that would provide high quality medical care at an affordable cost. As Dr. Kamlakar mentioned to you, Ramdev Rao Hospital was established in the memory of Sri Ramdev Rao, my father, who passed away in the year 2000. The hospital commenced operations in 2002 as a modest 30-bedded facility spread across 10,000 square feet. Through the support and commitment of our family and several organizations founded by Sri Ramdev Rao and Srimati Kumudini Devi, it has grown into a 150-bedded hospital occupying over 90,000 square feet. This growth has been strengthened through valuable partnerships. Our eye center was established with the support of the Hyderabad Race Club. Our 42-bed dialysis facility was created and is operated by the Bhagwan Mahavir Dialysis Foundation. Our blood center was made possible through the generous donation of equipment by the VKR Trust. Our cath lab, which is to be inaugurated on Monday, was made possible by the magnanimous support received from Dr. Reddy's Foundation. Generous donors like Dr. Shivananda Reddy and Dr. Rohini Reddy, the Rotary Club of Hyderabad Deccan, Deccan Fine Chemicals, Archesium, and many others have come forward to support our efforts. Today, our intensive care unit, emergency department, and radiology services are equipped with state-of-the-art technology and staffed with highly skilled specialists who are leaders in their respective fields. Despite offering advanced medical care, our charges remain significantly lower than those of many corporate hospitals, ensuring that quality health care remains accessible to those who need it most. Community service remains central to our mission. Through our school health program, we have adopted 10 government schools in the surrounding area, providing students with free health checkups and necessary treatments. We also operate a Rayati card scheme under which eligible families receive concessions ranging from 10 to 50% on in-house medical services. Today, Ramdev Rao Hospital serves an average of more than 500 outpatients every day. Demand for our services continues to grow, and our existing infrastructure is increasingly being stretched to its limits. To meet future needs, we are planning a major expansion that will add approximately 250,000 square feet of additional facilities in 2 to 3 phases, subject, of course, to our ability to mobilize the necessary resources. The third pillar of our mission is the Chaitanya Memorial Education Society, which stepped forward to establish the Kumudini Devi College and School of Nursing, student hostels, and the Chaitanya Memorial Center itself. The purpose of this institution is to create opportunities for learning, training, and professional development in healthcare and allied disciplines. This auditorium has been equipped with modern audiovisual technology to ensure that conferences such as this provide an enriching and engaging learning experience. On the second floor, we are currently establishing the Dr. A.P. Rangarao Skill Development and Simulated Learning Center, which will serve as a hub for advanced healthcare education and training. The center will provide critical care training for medical and nursing students and offer specialized instruction for postgraduate trainees in medicine, anesthesiology, pulmonology, and emergency medicine. It will also facilitate training in obstetrics, pediatrics, and a wide range of healthcare support services. Additionally, it will provide hands-on skill enhancement opportunities for practicing healthcare professionals seeking to upgrade their expertise and remain current with evolving medical practices. Our vision is to become a leader in medical education, skill development, and professional training. We look forward to hosting many more conferences, workshops, and academic events of this nature, bringing together experts, practitioners, and students to exchange ideas, share experiences, and advance knowledge for the benefit of society. As healthcare challenges continue to evolve, the need for institutions that combine service, education, and compassion has never been greater. Through the collective efforts of Ramdev Rao Hospital, Sivananda Rehabilitation Home, and the Chaitanya Memorial Education Society, we remain committed to serving our community and contributing to the advancement of healthcare and medical education. We are happy and proud to be a part of this ever-growing and essential mission. Thank you all for your presence, your support, and your commitment to the advancement of healthcare. Thank you, and I wish you all a productive and successful conference.
Dignitaries on the dais, participants, dear students. When I drove in this morning and saw the hospital, the first thing that struck me was my first ever visit about 10 years back at the invitation of Colonel Dayakar, then the medical superintendent. And after that, several memories connected with Colonel Dayakar flowed in. And then I literally feel that I was a witness to every single step that this hospital was taking. About a dozen visits since then. I see a lot of changes. They have added College of Nursing and this beautiful auditorium, which they badly needed. So I congratulate the management, the owners, and the staff members on growing so rapidly. Initially, of course, with the guidance and active help from Colonel Dayakar. I miss him badly. We are colleagues. So I once again wish the conference every success, and then God bless you all.
Dr. Mughali sir, I don't know how many books he has written, He is a sir. He has written countless number of books. At the age of 88, he is still writing books. He has recently published, got 2 books ready for publication, and he requested us if we can provide some space on this platform to release those books by our respected dignitaries. So we'll have that book release now.
I am told really 90% population in Andhra and Telangana has got that Arogyashri, or now of course names have changed, cards. Now fund is same, which was catered for 40% population, and now you are serving 90% population. That's why, this scheme is partly successful, partly failure. And many hospital in your own Hyderabad, they do not entertain the patient from these schemes. So that's why I said that practically we still have large population which remains unserved, and that is where the affordability still is an issue. So most of, I think, us at the government level or at the Niti Aayog level, we are trying to see how more people take private insurance. Now you will say, why you are propagating private insurance? Why not government funds are available to increase, let us say 40% to 90% population for the rest of the country? You must understand, government gives 1.8% of GDP for the healthcare. 1.8%. Around 2.75% of GDP is coming from the private sector. So even if I make 3 plus 2, less than 5% money we are spending on the healthcare in our country. While global average means poorest country to richest country, the ratio is 7.8% of GDP. So with this money, you can't run the healthcare. Particularly, I'm talking of 1.8% of the government. So that is why I think we are encouraging people in the, population at large to take the private insurance, because otherwise we will run into problem in time to come. So this is the present status of the affordability. The fourth factor of the universal health coverage is known as acceptability. Okay, acceptability means in terms of standardization, quality, and things like that. Now, there in 2005, when we launched the NABH, now that journey, of course, is very simple. I will tell you again for the students that when I was occupying the position of Secretary General Quality Council of India, there was a question in the Parliament. It was in April 2005. That people were coming to India for medical tourism or medical treatment. One patient traveled all the way from USA and came to Escorts for bypass surgery. Things started that time. And these people started asking the question that how do we select a hospital? Do they have any accreditation system in India? And that question from Parliament came to Ministry of Health, and Secretary Health referred to me. I was occupying the position there. And that is where we started, the journey of, because healthcare quality accreditation is not like laboratory accreditation. Because where in laboratory we have one standard, 15189 across whole world. But hospital accreditation follows a specific standard for each country. And then these standards are evaluated by International Society for Quality in Healthcare to give them the equivalence of, you can say, So that is where, we started developing the standard from April onwards. And, as usual, like Fauji, our Kamlakar is armed forces doctor. I choose who was supposed to come here, Air Marshal Pawan Kapoor. He should have been coming here, but he has gone out. So I appointed him as the chairman of the technical committee. He, along with 5 more doctors, developed this NABH edition 1. And this edition 1 was then submitted to International Society for Quality in Healthcare, and we got finally accreditation from ISQA for second edition. So this is briefly, one more aspect, let me tell you. When we launched this standard in 2006, there were hardly 36 applications in 1 year. Hardly 36 applications. Because people found what the hell it is so difficult, why unnecessarily, and things like that. Now, after 1 year, only 5 hospitals qualified. And luck would have been they were granted certificate by then President Dr. APJ Abdul Kalam in a big function. And that, I think, spread the word. Oh, NABH is handed over by the President of India. And I think next year we got almost 300 applications, And of course, the rest is history now. We have got, I think, total number of accredited or certified, and, impaneled number is touching 25,000. So that means you can say 25,000 hospital nursing or impaneled. That means they follow some little or some kind of quality norms or what we call patient safety. So I think this is where we are. I think we are on the path of achieving universal health coverage in all the 4 segments. The target has been set as 2047. Now, one more little aspect I will tell you, that why cost of healthcare is going up. Now, why the cost of healthcare is going up, I will give you one simple reason. In 1947, any one of the students can tell me what was the average life expectancy. Just guess what? What was the average life expectancy in 1947? 50. Okay, I think students might not have read this one. It was less than 37 years. Less than 37 years. Today, the average life expectancy is 73 years plus. So you can understand how this has happened. This has happened only because the advancement in the healthcare, diagnostic technology, our doctors, qualification doctors, that is the way. Now, all these things, when they are happening, obviously it is going to cost. So I think I keep telling people that quality healthcare, which includes everything, will cost. But absence of quality may cost you the life. Only thing is, we have to be prepared now that we provide some budget for our own health. Do not depend on only the government budget. Be prepared to have your own insurance. Otherwise, I think in the time of emergency, we may run into problems. So I think finally I will say my gratitude to the family of Raos. I really admire and compliment the service, human service which they have started way back. So I think I am standing in that kind of and of course Kamlakar, of course, is my very, very dear and old friend, and it is his one word I cannot say no. So I came. Now you can. So, why in the keynote, I want to cover a few things because students are here in good number. So, let me say the healthcare scenario. What is the healthcare scenario in the country? Let me begin from that. Now, we present government, rather even the previous governments have been talking about implementing universal health coverage. So, you must first know what is the universal health coverage. Universal health coverage means providing health care to the population at the cost what they can afford. So it is not about the free health. It is about the delivery at the cost what population can afford. That is why, most of the countries will have 2 or 3 segments. One is the below poverty line, to them they will give free. Above poverty line, some subsidy. And of course, the higher rich class, they will have to pay of their own. So I think that is the kind of scenario most of the developed country or developing countries have to follow. Now in India, the Ayushman Bharat scheme, I think all of you have heard about it. It was launched in 2018 for this very purpose, that 40% of population, because it is estimated at that point of time, I'm talking of 2018, that 40% of India's population is below poverty line. So that is the concept this scheme was launched, and I think 40% is covered by that. Another 8% population is covered by CGHS, another 4% covered by ECHS, and things like that. And recently, 70 plus population also has been included in the Ayushman Bharat. So if you add all these things along with 14% of the population being served by the private insurance, then we are touching somewhere 65% of population today has got some or other cover. This is not a small thing. 65% of population has cover for the health.
Doctor,
Okay, right. So I think this is the fundamental. Now, what are the components of the universal health coverage? Again, for the students, the 4 components are making healthcare available. Available in terms of number of beds, number of doctors, number of nurses, number of allied healthcare professionals, and of course, diagnostic laboratories or overall healthcare infrastructure. So that is the first component of universal health coverage, making healthcare available. Now, where are we now? As per WHO, you need 3 beds per 1,000 population. Fine. Now, how many beds we have got? As per the survey of 2023, after that, of course, number of beds must have rather increased. We had 2.1 million beds, 2.1 million beds, of which 1.3 million beds are coming from the private sector and 0.9 million beds are coming from the government sector, public sector, what we talk. So what you need is almost double the number to make it 3 beds per 1,000 population. So I think we have a long way to go to reach the goal of 3 beds per 1,000 population. That is about it. As regards to number of doctors, I think we already have got more than 1.3 million doctors available, registered with the National Medical Commission. But the issue here is that unfortunately, the MBBS doctors we do not really count practically for the purpose, the way we are delivering the allopathic healthcare. So if you only take the postgraduate and above, the ratio is coming 0.65 doctors per 1,000 population. So I think here also, I think the recent initiative by the government, various state government, each district is going to have 1 medical college, and number of PG seats also have increased now, almost touching 80,000. So I think gradually, maybe after 3 years, you will be able to find that our country has got sufficient number of specialists to serve the community. Nurses also, again, number of schools and colleges. Here itself, we are running the school and colleges for the nurses. So that also number we are going to make very soon. So this is about the availability. Now, what about the accessibility? That is the second component of the universal health coverage. Now, accessibility means providing health care to the population within the practical reach. That means, let us say the primary health care should be available, let us say, within the 10 kilometers of the range. Secondary, let us say 30 kilometers of the range. Tertiary care, 50 kilometers of the range. This is a general, estimate, general, norms which is followed. Now, problem what is having today, I'll give the example of Telangana, let us say. Now in Telangana, 100 bed and above, 100 bed and above are those hospitals which provide tertiary care. Now, how many are there? As per again 2023, we have 126 hospital with the 100 bed and above, out of which 118 are in the city where we are, Secunderabad and Hyderabad. So I think you can understand rest of the Telangana population have to travel to Hyderabad only for the tertiary care. So this is the serious setback for our country. And this data, not only Hyderabad, applies across. In Tamil Nadu, the 50% of such beds are available only in Chennai and Coimbatore. So I like that all remaining countries also have.